Yes, please.
Great, great, great.
That
Well, then,
would be that
yeah,
would
yeah.
be my honor. So to be on YouTube
Cool.
or like record. So thank you, thank you. Yes.
Awesome. Yeah, yeah, we look forward to it. Yeah, awesome. Yeah. Yeah, I've been meaning to get you involved with this group for a long time. I should, yeah, I need to add you to the regular. I'm not even sure if you're on the regular invitation.
No, but that
Need
would
to
be
add you.
nice. I
Yeah.
love to hear, the updates from the work group and also like the to connect and collaborate more in the future. So that would be wonderful.
Yeah. Well,
Uh-huh.
Yeah.
I just replied to your latest message on the ASN group
Oh,
uh,
yes.
because I haven't been in there for a long time. I thought
Yeah,
I better do something.
we miss you, Dr. Solis, and I will show you the slides of how progress and update of our ASN forum now. So we
Yeah.
have a lot of many participants from different countries. So the we are more active now. So please, we miss you so much, Dr.
Yeah,
Solis.
no, no. In in October, I'll come back in strength. The thing is that right now I'm writing four papers at once. And if I
Oh wow.
contribute a lot to your entity, then I'm got less stuff for those four papers. So I have to wait till those four papers are done. And then I'll come back, be just as active as I was before, maybe with more
Yes.
poetry, and we'll know then whether any of
We
my poetry got
right.
listed or long listed for the CBC poetry contest.
Yeah, I
We'll
was
know
like
either that I'm a prize-winning poet or a failed poet.
I was
The
wondering about the
verdict will be
poetry.
in.
Yeah, we miss your poetry like so much. So please do.
I'll be back in October for sure. Yeah.
That's
Perfect. Perfect.
Oh, you're working on four papers at once.
Yeah.
I'm having an absolutely desperate time, and it feels like I'm working on minus one paper.
Yes, I understand. Yeah. Yeah. That,
It's
yeah.
like my,
that
my other mathematical invention, which is work so good that it has p-value less than zero.
absolute certainty, no uncertainty, no span of indeterminism. It's
Right.
wholly determined. Yeah. Yeah. That's
And
great.
especially in renal work, I believe in having good p-values.
Yeah. That's good.
Uh,
Excellent. Yeah.
I I think what I'm going to do is go ahead and I have a few slides, introduction, and usually
Sure.
people show up late. So by the time I finish, we can turn it over to you. But I'm starting. Thank you so much for giving this talk. And I'm sure by the time I finish with this little introduction, then we'll have a lot more people on here now. So thank you all so much for joining today. And we especially are glad to have Dr. Wisit from Mayo here today. Thank you so much for your participation. And if you have any ideas for the group, just feel free to share them. I want to bring to your attention the Banff next Banff meeting, which is in Banff in 2026, October 5th through the 9th. So we need to keep that in mind. I'm trying to keep it in mind because we're actually trying to work on another white paper before then, hopefully. For this working group, because we have a few white papers. This is our last white paper, and I just put this in, so that everybody can remind you, and also Dr. Wissett, so you can see this. Is that we have three big aims. We like to build image banks and collections, and then algorithms that we can share, and then competitions and trials, and then eventually we hope that our efforts will come up with Banff algorithms. And we've done this in a number of ways. It's gone really slow in some ways and faster than I thought in some ways, but we can fill you in more on that in the future. And Dr. Soles actually came up with a fourth sort of aim for us is to rethink the innovation timeline. And that can include a lot of things. So, so we have some upcoming meetings. In 2 weeks, actually, Shannon, who's on here, hopefully, and I can help you with that too. And Ashish is going to talk about one of our efforts. We're actually putting in for a renewal for phase 2 of an NIH grant, small business grant with Kitware. They're a company who builds these sort of AI algorithms and also a sort of a digital slide viewing platform. And so, in 2 weeks, we'll hear more about that again. We've talked about it intermittently. And then in 4 weeks, some collaborators of mine from Georgia Institute of Technology are going to talk about some multicolor staining and spatial omics approaches that they have. Dr. Amit Kuskin and Aditi Kumar. And then actually, Maisie, who's on, is going to speak in 6 weeks. And this is going to be on his talk that he gave at the World Transplant Congress. And I look forward to that too. And so we're working on talks after that. And I also wanted to mention Dr. Wisit actually, is it okay if I call you Dr. Wisit?
Oh, yeah, yes, please. Just call me Wisit.
Okay. Anyway, yeah, he heads up with Kim, Dr. Soliza here, the ASN sort of AI powered kidney care network, and he may mention that, but it's something. If you're a member of the ASN, please subscribe to that. But I think right now I'm going to turn it over to Dr. Wisit, or Wisit, and he. I don't need to give him an introduction. If you read any kidney pathology literature, or kidney nephrology literature, you'll see his name. He's does a lot. He publishes a ton, and he's also very active in the community. So he comes with no sort of needs no introduction from the Mayo Clinic. So I think I'm gonna just turn it over to and please let me know if you have any suggestions for speakers in the future. So I'll turn it over to you now. Thank you so
Thank you.
much.
Thank you so much, Dr. Faris, and also thank you, Dr. Solis and Dr. Faris, for invitation, and nice to connect with everyone. I've seen the many familiar names and faces here already, like Dr. Cornell. We miss you so much here. So let me share my computer, the screen. Okay, all right, and can you see my
Good.
computer screen? Okay,
All right.
everyone. Okay, all
It's
right,
good.
very good. So my presentation will be around like 30 minutes to 40 minutes, and then feel free to stop me anytime, or the if the we going too fast or too slow, let me know. So today my talk, I'm going to talk about AI in nephrology, kidney care that I learned from Mayo Clinic and also from ASN community, and I'm going to discuss and apply to the applications that the can be relevant to the renal pathology and digital pathology, and what is the current application and how to move forward in our perspective. So I have no disclosure other than, as Dr. Faris mentioned, that I have worked with ASN, building ASN community forum to create the participation in AI education and discussion for ASN. And I'm a nephrologist, so I'm not a renal pathology expert. So if there's anything that I said about renal pathology that the not completely into details, let me know. So as Dr. Forrest mentioned already, that the ASN, we built the AI steering committee the earlier last year, and I'm one of the members who the help participate and advance the AI in nephrology, especially like AI education for our nephrologists and also our trainee. And this is my experience in AI. It started by learning AI the about 3 to 5 years back on machine learning, how to create it, how to assess it, and learn to collaborate about AI with many experts like all of you and I also use AI in everyday practice, both the in personal use as well as the for patient care and research. So now the nowadays we cannot say that we don't need to know AI, since it's this core skills that everyone should know the for now and for the future. And we doctors, we are not in the list that the without the AI exposure, so we are certainly in the occupation or in the job that need to learn AI, and AI already relevant in our the daily life. And this is the Mayo Clinic, the AI and electronic health record, the history. And in 2017, when I was in the fellowship, I learned from our renal pathologist expert, Dr. Cornell here, Dr. Alexander. At that time, we used different electronic health record. We switching to like Epic, and at a lot of nephrologists, a lot of physicians at the time retired because the we the as human, we sometimes we feel comfortable at our comfort zone and we don't want to adapt, but or learn the new things. But it's important you see that we move on with the new electronic health record anyway. And last year in 2024 we implemented the AI in our electronic health record. Many the were skeptical about that, but now we the I would say almost full stream with the AI implementation. The and we continue to the give the AI education to our staff. So the in the transplant nephrology or kidney transplant, as you the we all know here that what we have innovation in our area that moving forward, the transplantation for the hot topic here is organ perfusion, for example, the innovative treatment. And the we cannot the ignore the most one of the most important, which is the AI integration in our workflow, such as assisted the biopsy interpretation or AI assisted allocation protocol, and as well as the xenotransplantation. So Dr. Alex Luby recently the very nicely highlighted this the advance in emerging technologies and xenotransplantation, how to incorporate AI, reshaping the transplantation. And this is in Nature Medicine, and also the feature in during the World Transplant Congress that we recently just had the earlier this month as well. And we can see these are example of the innovation that we currently have that we moving forward. And in addition to the iBox system that the everyone all know about, this the model that predict the long-term graft survival. The we here the digital the pathology work group, we can see that the Banff automation system also been the highlight as well. And as you know that CNN model able to reclassify the Banff criteria of those pathology into the more accurate classification. So what problems that we the think they are important in kidney transplant or transplant nephrology that AI can help us the solving, the of course to help predict those the kidney allograft outcome, rejection or organ allocation. Here the with the digital pathology group, the one that can help us also is the differentiation or scoring of the IFTA and fibrosis and health, the with the issue that we dealing with the biopsy interpretation variability. So this call Moravec paradox in healthcare, right? So the something that easy for human, for example, those like empathy that AI the do not have or not better than us, or something that easier for the AI. For example, those large scale data analysis, or the those that need to detect like subtle changes, especially in those like pathology that everyone here dealing with. Of course, we love to see collaborative intelligence, not only AI that working for us, but we also supervising or using AI as our tools. And as I mentioned before, the studies that published consistently showing that what AI can do the well and helping digital pathology is to the like identify those subtle the histologic patterns, for example, like help scoring the IFTA, or the identify polytubular capillaritis. Of course, the our renal pathologists and here the the we talking with the experts, but there are some centers that the a lot of time consuming and a lot of the vulnerability that okay, this the renal pathologist that I talked to tell me that oh, there may be mild polytubular capillaritis, the 1+, another person say 2+, or not at all. So the CNN or AI, the model can certainly help us in those the subtle histologic patterns that a human may miss. So I'm gonna mention the briefly into those like the AI and machine learning algorithms, as everyone already know about this the subtype or subset of the AI that we have machine learning as a subset of the AI, and we also have deep learning and generative AI that is now the training that is the AI that use deep learning model to generate the new contents. So supervised learning, this is example of supervised learning in the digital pathology that uh, the models used to the like predict the outcome, right? Predict the label, the variable, right? For example, glomerular segmentation and classifications also the supervised learning. Uh, Quantify the IFTA, also supervise the CNN, and those are the models that help the classify the food process assessment, or the identify the transplant rejection lesion. So the famous iBox, the model by Dr. Lupi and team, also called supervised learning, right? Because this is a model that use multiple the variables and the accurately the perform very well in predicting the allograft survival, which is predicting the outcome. So we call supervised learning. How about unsupervised learning in the literature or in the AI the world? You may hear of the clustering approach. What are they? So these are models that do not have uh, like the label of the outcome, but let the machine learn about characteristic and phenotypes of the data we have, or subset that we have, or the patients that we have, to cluster and identify distinct phenotypes. For example, our group, the here we identified the vulnerable, the subgroup of the uh, African American kidney transplant recipients by UNOS database, and let the machine learn, an unsupervised machine, and let the machine learn the how unique subgroup of these patients are, and they have different the characteristics, and also the those characteristic, those the different cluster have different outcomes. So we can then identify the those subgroup of patients that the have poor outcomes in those group, and identify the specific policy that can help with each subgroup. For example, this is very relevant the study to the our the Banff digital work group here, which is the study that use the what they call semi-supervised clustering, but the in details this study using the unsupervised learning, which is the clustering approach to the let the machine learn about those the histological phenotypes of the rejection and identify unique the clusters, and we can see that each cluster have different outcomes when they match with the outcomes the those the cluster based model the identify prognostic linkage to graph survival better. And this is another example of unsupervised learning that published by Paris Transplant Group team as well, that use unsupervised learning to understand more about transplant glomerulopathy. That transplant glomerulopathy is not just only the one the whole the set of the transplant glomerulopathy, but when the machine using the characteristic of those like the patient characteristic, immunological and histological, can the distinguish subtype of the transplant glomerulopathies into different subtypes that associated with different outcomes. So those are example of supervised, unsupervised, and there are some reinforcement learning as well. But I would not go into details. But I want to emphasize more about something exciting like the generative AI. That now we are in the era of the generative AI that not only learn and predict and also can create the new content. So we may hear the term of NLP, natural language processing, which is the AI that allow the machine to understand the and analyze the text. And what is the LLM or large language model? Is the AI model that can generate the text, right? So the LLM is a subset of the NLP and deep learning. And what is generative AI? Generative AI is a model that can create the new content by deep learning. If it's creating the text, then we call the large language model. But if it's created the images, maybe using different models such as diffusion models, for example. And it's very exciting, as you know, that this month in August now and earlier this month GPT OpenAI just released GPT-5 which is the most latest new model. And we can see that they claim that it's faster and also the better reasoning and giving us more accuracy. I'm gonna touch on that if it's really true or not. Or you can use GPT-5 thinking that use reasoning model that the use longer reasoning chains and may have higher accuracy. So for the IQ, we can see this is just released yesterday. The GPT-5 the have achieved the IQ performance higher than O3. That was we thinking that it's like the best model ever already. Now they claim that GPT-5 is better, and from the IQ test, that is the truth. And with the model, it's not only the model, but also how we giving the instruction to the model that we call prompting engineer. You may hear the term of prompting engineer a lot, and prompting engineer is the basically how we give the instruction or how we ask the model to provide the output. So we can do zero shot prompting, which is what we do in every day. We ask the very brief the question or give the brief instruction to the model and ask the model to do something for us. We can use chain of thought prompting that you may hear this term to ask the model not only the answer, but also please explain step by step. And by doing so, the it has been shown that when you ask the model to do step by step or explain, the model tend to give more accurate the result. Or you can do role prompting if you want the your output to be specific the to each the job the assignment, or you can do meta prompting, which is what I have done a lot, which is the improving my own prompt. Because as you see that sometimes you ask the language model, large language model, to give you the output, different the wordings, different prompt, you get different outcomes, and sometimes you like the each the output better, and you can ask the AI or Gen AI to improve your prompt. And I do that the very often when I see that my prompt works, and the if I improve my prompt, I even get better the output, and I save them now. I This is as of the May, but the I save a lot of prompts now. I'm so proud. I have almost 800 prompts now. The set that I can call, right? Call function when you using them. So in my daily life, personal use, I do a lot of like the blog posts, educational posts, and these are very helpful the for my workflow in both personal and we're gonna touch bit on the clinical use a little bit later on too. This is a workflow that we dream the like that is and thinking about like for the outpatient how we incorporate AI from the pre-visit to like post-visit. And what relevant to our digital pathology is we the here we the trying to work on how to use AI to help with the pathology interpretation that can integrate into the workflow and help with the diagnosis, and the those are important part. But the part that already implemented in the practice the nowadays in my nephrology daily life is the documentation and note generator. And now 99% of the time in my practice, the when I see the patient in the clinics, I don't type my notes anymore. I don't the dictate my note anymore. I We have AI that listening to our conversation and transcribe the into the medical note. It's called the abridged AI as a name, but it is the basically one of the ambient AI that is the AI that I go to the patient with the patient visit. I have my phone, I have application, the that called a bridge AI that can listen to conversation, the between me and my patient, and then transcribe into the medical note for us the when we seeing patient. And you can choose the concise and comprehensive the form of your note. And this is the just the started because we the as the no, at Mayo Clinic recent, the Department of Medicine, the grand round, we the working on expanding the ambient AI into many workflows, both inpatient, outpatient, and of course, the it may the apply into the renal pathology in the future. That, for example, when we're looking at the renal pathology report, it's not only that we're reading the report. The maybe in the future we can listen to the description of the what you're talking to the AI, the when you're looking to the microscopy, and then AI that generate to the voice and also describe to us the as well. And now the at Mayo Clinic we have like uh, the ability to link those report to the digital pathology, how those the slides look like in the future. It would be the nice to hear, you know, the description from the AI in the voice, and also can link the with the annotations. That is a possibility. So another point that we now use is the inbox messages in the Epic, right? And we use large language model with the patients that I'm seeing outpatient. The we have like patient questions, patients send us questions, or we got the lab result. Now we have the large language model that fine-tuned to medical use and draft those the messages for us that we can draft to the patient. This example that I draft, I send the patient messages, patient reply back, and the LLM that incorporate into the workflow draft those for me, and very the relevant and the fine tune into my clinical use. This is not the real the patient. This is my sister, and my sister the picture as her allow me to use. So anyhow, this also relevant that in the future we may apply this into the inbox messages for the renal pathologist as well. The nowadays the I'll give example at Mayo Clinic. Every time we do a kidney biopsy, I am so excited because the after biopsy I would like anticipate that okay the today and tomorrow I'm gonna get a call from Dr. Cornell, Dr. Alexander, Dr. Seti about like the biopsy, and we have the communication via phone. What should we do next? And that's a great communications. The I like those. The at the same time, there are some other institutions that the I worked the outside Mayo before, and it's so hard to try to find the pathologist. I'm sorry to say that, but you all like busy sometimes like in the meetings and also like with other calls. It's so hard to the communicate, and there are the efforts that the AI for the institution that can the like start using AI to help with this communication to nephrologists, to pathology team, or to the outside the pathology the consultation. So, and you can see that this is already implemented in real clinical practice because of, we call this as a low risk. Of course, there are some hallucination or, you know, inaccuracy, but those the nodes that generate the we human we need to the supervise and confirm the finding and no direct the clinical decision involved. Those model that the propose the treatment identify like the polytubular capillaritis or like FSGS or rejection, those called moderate risk. The right we have not implemented yet, but we have the those model into the point of like external validation, and hopefully in the future will be federate learning, and then the incorporate into the electronic health record. And even those high risk that the adjusting the treatment that automated by AI, then it's gonna take time to implement. So I'm gonna now go to the patient care, like the medical knowledge questions and answers, how we use AI to help the improve our workflow. So this is our study that we the have done like more than a year now. We assess the performance of the GPT. At the time it was GPT-4, the in, you know, the answering the questions of the NEPSAP and KSAP, and we can see that the GPT-4 the perform the quite well, above 70%. However, the GPT still the not outperform our nephrology examinees. We nephrologists, we consider ourselves smart too. So the good to see that when the quality examinees the outperform the GPT, but the you may say that now we have GPT-5, the what's going to happen, and also the what's going to happen and relevant to the digital pathology, or if the GPT able to answer the questions on kidney pathology well or not. This is uh, the study that we published, and thanks to Dr. Cornell, we tested GPT for the on the kidney pathology exam questions, and those questions are like 39 questions, really well written questions. The from my understanding, the design and certified by pathology team, the and Dr. Cornell, the is the one who created those questions. So and it's hard question. I was the a fellow who also the took that exam, and I still remember that time that I took the exam, and I really afraid that I was going to fail. Thankfully I passed, and you can see the that GPT for accuracy in answering Dr. Cornell's the questions, still not able to the win our trainees. So basically, the of course those the generative AI GPT still not able to the replace our the renal pathologist the work and expertise. How about GPT-5? It just released. We need to understand more about their performances. But this is a problem that I have seen already for the past week. So, and not only me, and many AI user in the community also have the same problem, that when you the ask and put the instruction to the GPT-5, you get the answer. And of course, GPT-5, if it's the highest performance model, you get the very great answer. I accept that the answer looks so nice and very relevant, and I love that. But more and more that you ask them, sometimes you see, the answer is not really accurate, and it's very obvious, and there are some hallucination. And that's because sometimes they switch to other GPT, the 5 that minimal the size, or the low performances, without telling us, and that's really making us the like the scared of using it, like, oh, why suddenly they change the performances. But I'm sure that in the future they will address this concern. But this is the problem that the I personally have the been encountering for the past week. And how to improve the model then, when we say that the large language model only is not the able to answer our medical questions the adequate enough. We have the technique that we call retrieval augmented generation, or RAG, or we have fine tuning the technique to improve the generative or large language model uh, in order to improve its accuracy and reduce the hallucination. And here at Mayo, we have open evidence, and also everyone now can access open evidence. I am sure, uh, the when I was in Italy, I was able to use the open evidence over there. When I was in Thailand a month ago from my mom, I could not use it. So of course there are some limitation to some countries. This open evidence is the AI that the fine tune the model to medical use, and also use what we call retrieval augmented generation, which is the knowledge base that the coming from the PubMed base. So you can see that when you ask the question to open evidence, it gives you the relevant answer, and also not only that, they give you the references that you can the click the link that they all exist, and also mostly are ranked from high impact, such as New England Journal Medicine, the JAMA, and it's also the fine-tune and use retrieval augmented generation that the from the communication is updated the every 24 hours. Therefore, the paper that you publish the 24 hours on the PubMed, when you ask the questions, you get the more update the answers than up to date that may be updated like 3 to 4 months ago. So, for example, you asked about like, should molecular diagnostic be routinely integrated to kidney transplant pathology? The open evidence say not yet routinely integrated, and give the like relevant references that the consistent with the statement in major the transplantation journals, the which is nice that we can use for relevant references. And education, I'm going to touch briefly, since we're going to talk about how to promote the AI education. Now in nephrology fellowship, we have team to summarize the teaching points to our fellows, our trainees, our residents. They love that. This is the evidence that they give the love the here to the model, to the emails, and they also enjoy learning. They don't feel that they get, they got left alone. We are always with them. We summarize the important points for them. We also use the AI to help generate the journal club discussions when no one asks the questions. Then we use the questions that relevant that AI suggested. And we can see that our nephrology fellows the got #1 in training exam. So thanks to not only AI, but we all as educators for our trainees, right? And also part of this the innovation and strategic plan that we have to enhance the education the by AI. Thankfully, I self promote here that I got the Teacher of the Year award. So we also have the plan for Coursera, the program that provide the AI education to all staff at Mayo Clinic, so we can advance the healthcare with AI together. And again, as the national and international ASN the started AI power clinic care network community, and thanks to Dr. Solis also like participate and give us the insights and his the knowledge and experience. So it's important to the incorporate the AI education into our community. So we learn together. Now we have participants the up to 28 countries around the world. And for the research, we also trying to incorporate AI into the research platform that can help extract the data and get our research workflow better. Mayo Clinic, as you know, we started the Mayo Clinic platform, which is the collaborative, the platform multi-center that the prospectively collecting the data. And we also have digital pathology data that Dr. Alexander may know more in details about this digital pathology data that we have at Mayo Clinic platform. And ultimately, what we think that is the future of the AI models are multimodal data that not only the identifying pathological the lesion, but also integrate the the data from digital pathology into different the imaging the modalities, as well as omic data and structured and unstructured data. in order to create the multimodal the model prediction. So you may say that this is a dream and what Wisit talking about but as you see that in cardiology they already advanced. This is the Nature Medicine that just published this year. They incorporate the those the modifiable and unmodifiable factors with the like genetics, lifestyle, imaging, and predict the risk of the coronary artery disease and predict over time. And you can see that the multimodal, the prediction model, the have done very well compared to other models that exist in literature. And we can consider that too. It's a long way to do and work for, but it's not impossible. What we think that in the past it was not possible, we've seen that it's happened very fast in the past 2 to 3 years. So we have the many the modalities like light microscopy, IFEM, and we can the learn to combine them more efficiently and create the what we call multimodal fusion prediction that include those the modalities plus the structure and unstructured data, patients, the report, the out and patient characteristics, as well as those omics and genomics as well. So and our the like dream model would be multimodal, and as Dr. Lupe emphasized that those models should also be continuous update and generate the prediction risk the in each specific time for timely intervention. So uh, I'm going to finish soon, and for ASN, we still the see that we lack the expertise in digital renal pathology, renal radiology, and genetics and omics. So, in 2026, we will the very likely the invite the digital pathology team to the participate and join our group to help advance the AI in kidney care. And this is the last 2 to 3 slides that we can see that this is the AI future of AI in healthcare in general, right? That the NVIDIA and OpenAI the have foresee we now in the the era of generative AI, the next step would be agentic AI that can automate the tasks for us, and then physical AI. So, for example, the arrange the coordination care, the arrange refill labs, refill the medications for the patients, or the robot that going to the bedside and doing biopsy, or doing ultrasound for us, or the robot that doing the kidney biopsy for us. So it sounds like it's far from here that we are presently, but we can see that uh, in Tokyo, the if you visit this hotel, there's like the hotel that there's no receptionist, all run by the computer and AI, and receptionist is the dinosaur. All right. And also we already have a robot that perform the dental work for us that without any dentist supervise at all. So anything is the possible in the future, but we need to do it safely and get the human in the loop and hopefully collaborative the between human and AI. And thank you so much for having me.
Wow, that was an awesome talk. I mean, I have so many questions I could ask, but
Yeah.
congratulations on all your great work. But I'm just going to open it to the floor and let other people go.
All right, thank you. I seen Dr. Cornell mentioned in the fellow fail the exam, if the fellow fail the exam, they get to take pathology rotation again. Okay.
Yes, it's a reward. Um,
Uh, yes, that's why I was so scared. I
no, you
remember.
should have been scared. You should have wanted to fail it because then you can spend more time with us.
Yeah, that's the plus that we got to spend time more with renal pathologists. At the same time, I'm super proud of myself when I pass your exam. It's very great the great exam. And
No,
also you have like the time, like your timing is the question, how many minutes is it, like the real world. Okay.
can I ask a question since I'm
Yes.
no. So, first of all, thanks so much for this overview and everything. I I guess I have maybe it's more of a specific question, but so much of the time in renal pathology, we're dealing with incomplete information. And also, we don't know everything. We can say something is whatever, rejection, but we aren't defining rejection that well. Or we're saying something is interstitial nephritis, we don't know the cause of the interstitial nephritis, or C3 glomerulonephritis, and we don't know what's causing it. So sometimes it seems like we're giving a specific diagnosis, but that it's not that specific. I mean, it's not, we can't always give a causal diagnosis, which is what we try to do in renal pathology. So how does and also dealing with incomplete information. Maybe the nephrologist didn't send all the lab tests that we would have wanted when we're looking at the kidney biopsy. Maybe we don't have all the clinical information. Maybe, you know, maybe the pathologist gives the incorrect diagnosis.
Yeah.
So, how do you deal with incomplete information and inaccurate information when you're training different algorithms and also interpreting I guess, the output of these algorithms?
Yes, this is a very great and challenging the this is a great and difficult the question to answer. And this is the why I don't think that the AI model can replace renal pathologist job like the anytime soon. The Of course they are improving, but the renal pathologists the that have uh, like expertise like you mentioned the are very important in the workflow. And what you mentioned, Dr. Cornell, always remind me about like Dr. Favenza that always Fernando Favenza that always the giving the discussion or emphasize importance to us that the diagnosis from the outside, or that's why some many patients that come from like small institutions or the that don't have the expert renal pathologists the come here for second opinion, that many times we've seen different diagnoses and then give different the treatment. So that's why the Dr. Favenza the saying that okay, it's gonna take a long time for the AI to enable to do all this because the misdiagnosis, the also like the missing the data that we have, the so but at the same time the missing data they are and they have been the efforts to use the AI techniques to the like also impute those data by AI, like predict what those missing data are. Of course, they are not like the efficient now, but their accuracy are improving. So in the future, there's possible that those missing data will also be the predict, like for example, those like models that the guessing the like what are the next words are, what are the missing pieces, and those AI can hopefully can the tell us all more about those missing pieces better, and then the can predict the outcome better, or the also able to like for example another possibility is to create the digital twins the of the patient that with this missing informations, missing data, if those the data that fulfill with the first possibility or second possibility, and what the diagnosis can be and what outcome can be. So there are many opportunities for AI in order to help with those problems, such as the impute those missing data by prediction, or create the digital twins and the put those missing the information the in and see when the possibilities are different, what are outcomes that different. So those are the what I think and foresee that is likely going to be. In the meantime, the what AI that I would say can do kind of good the right now is to identify those like something that quantitative, or like for example, is this the biopsy having like follicular capillaritis, or like please quantify the IFTA or something like that. But to make the complex diagnosis is still taking time, like you may emphasize to the Cornell. So, and we miss you.
Thanks.
That was a great question and answer. I think Mazi was the next person who had a question.
Sure. Thank you so much for the great talk, and congratulations on all you have done so far. Actually, the talk was so great that my questions were popping in my head like popcorns. I asked one of them. So you had a table that said some things come to humans more naturally and easily, and the opposite for the. And you mentioned empathy as one that doesn't come to artificial intelligence more naturally. And I was wondering because. Yes, I agree. If we define it as the ability to understand and share feelings of another, by definition, AI cannot sh have empathy, but it can show, it can pretend. And I wonder if there are any studies that actually looked at if patients are more comfortable talking to an AI than a physician.
Yes, you raise really great point. You raise really great point. So in fact, like you mentioned completely the true that if we blind, and there are studies in both internal medicine and also like for psychiatry, that the when we blinded the patients about the answers, if the answers are from the AI, are from the physicians. In fact, those answers that we replying, I mean AI replying the via the inboxes, the have higher the empathy the level, and also making patients more satisfied and more relief in terms of those the answers. So the those perspective on the empathy that the AI still lag behind human. Of course, in term of the answering the questions, I think AI can do better the based on the studies that shown. But empathy that I think we can do better is the and patients like talk the face to face, or talk on the phone, that like this, that it's not AI talk for sure because I have a strong accent. Then you get my sense of like how is it, like how the he respond to the patient, how the patient the feeling about this conversation. In our nephrology practice, it's so hard the to like, and it's take a lot of experience to the discuss with the patient that okay, you to the point that you need to start dialysis, and family the like get involved, some cries, of course we also sometimes cries because of this, like there are a lot of emotions, it's like life the you know making decision the very very important. So that's why we think that also AI cannot replace nephrology job because of like design about the life saving procedure, whether like we survey the patients not in the study yet, but we ask if AI going to tell you that you need to start dialysis, will you believe AI or not? And they don't, they trust us more. But yeah, I hope that answers your question.
Yes, yes. Can I ask another question?
Yes.
So if we think of AI as an intervention and we're saying addition of AI potentially can improve outcomes, where do we draw the line and say these are the questions that should be answered by a randomized prospective clinical trial?
That is very the great the question. So right now, I think the for as an American Society of Nephrology, that's also the question that been discussed, and we don't know the answer yet or not. And what do you think, Dr. Risey? I want to hear your opinion on that too. Yeah. So there are a lot of controversies on those what should we the use AI for the clinical trials. But what we have the been thinking about proposing about, we don't know that this is the right answer or not. But of course we prioritize on the those that the changing the outcomes to the like big population base, like the global impact first, and also the those that the the we don't understand the pathophysiology and the treatment. So there are two the outcomes that we're thinking that very likely that in the clinical trials will be the coming for AI first is like the one that global impact, this rank the very top, and another one is like the diseases that currently have no the treatment options well, and identifying the pathway and drug discovery.
Thank you.
Well, that was awesome. So, I mean, congratulations. And any last really quick questions or comments? I know Dr. Wisit is very busy at the Mayo Clinic. People are very busy, but
That was a very nice talk, Dr. Wist. So regarding
Thank
the
you.
FDA, I think one of you guys has to submit a proposal to the FDA. They will tell you what more they want to see before they allow a trial. And one of you should take that initiative and find out what they need.
Re- thank you for the kind words, and that is a great is a great point. The yes, we will have follow up the answer on those, but yes, that's correct. That's very great point. Thank you.
well, well, thanks again. I know you're so busy and you do so much. So I think we'll call it a day for today. But we meet every 2 weeks, so hopefully we'll see you again in the future and maybe ask you to come back and speak to us again. And thank you so much.
My pleasure, and very happy to come back to participate. All right. Thank you,
Great. Thank
everyone.
you. Y'all take care.
Bye.
Have a good
Thank you.
day.
Take
Thanks
care.
a lot.
Bye.
Take care. Bye bye.